The lecture will be delivered by Dr. Nahid Hamada, consultant obstetrician and gynecologist and subspecialist in reproductive medicine and surgery. He is the director of Reproductive Medicine Surgery Center in Kuwait, New Muassat Hospital. Dr. Hamada.
Thank you very much. Thank you, Mr. Chairman. Good afternoon, everybody. I would like to thank Merck Pharmaceutical Company for inviting me for this presentation. I would like as well to congratulate my colleague in Bahrain for their first international meeting in Obsangani. I hope I can fit this presentation in the next 30 minutes. I don't have any commercial to disclose. My presentation is going to cover this point. Basically, we have introduction, and we divide the factor affecting the outcome into two categories. Patient characteristic and its effect, like the age, ovarian reserve, and how we assess the ovarian reserve by doing AMH, basal FSH, antral follicles count, and ovarian volume. And we go for the second one, like cause of infertility, all the causes for fertility, and we concentrate in endometriosis, hydrosalpinx. And then we go for duration of fertility, how it's affect, and history of previous pregnancies. And then lifestyle. I'm not quite sure. Do we have laser? Must be. And the lifestyle, including obesity, smoking, exercise, and if you'd like to add as well, alcohol consumption and smoking. And we go for ethnicity, and then clinical characteristic, and its effect as well, like stimulation protocol, number of the embryo transferred, techniques of embryo transfer, and embryo quality, and cryopreservation program. And then, of course, we'll talk about ICSI treatment if we have time, and IVF lab, and we're going to conclude what we have been said. As we know, more than half of our patients, they need some help in some stage of their life. So it's about 48 to 50% of the population, if they're seeking pregnancy, they need some help. And we are very lucky because we increase our ability to help this kind of patients, especially the last few years, when you introduce IVF and ICSI as well. If you look at the number of the IVF cycles through the last few years, this is from the HFEA data in UK, look from 1991 to 2014, the number of the IVF cycle has been increased significantly. Now, understanding this factor is very important because it is some of this factor you can change it either surgically or medically, and then you can help the patient and improve the chance of pregnancy. Basically, that's what we need to do because we need to help the patient have a better chance to get pregnant. And of course, we need to understand the factor to compare published data from different IVF centers. Either each center will say, I am the best, and everybody actually claiming he is the best in this kind of treatment or the other treatment. And basically, as you know, the modern medicine, we have to involve the patient in the decision making. So if you understand this factor, you're going to tell the patient about her chance of pregnancy, and then she will take the decision as well and help you doing that. And of course, with that will improve the patient counseling. Understanding this factor is important not only for IVF specialists, but as well for the gynae, so gynae consultant or people practicing gynecology, because they send us or they refer most of the patient. So I think understanding this factor is important from their point of view as well. There's many variable factors, more than 150. I mean, you're looking for the age, ovarian volume, ovarian reserve, FSH levels, technique of embryo transfer, the clinical technique behind that, and you can count many and many and many. Of course, we are not going to go through all of them, but try to find the most significant factor affecting the IVF or ART outcome and discuss it briefly. This subject was very hot a long time ago. We wrote a chapter when I was doing research fellow in Birmingham and in Cardiff, and then because everybody would like to understand this factor, especially people practicing fertility, to know how they can help their patient and improve their chance of pregnancy due to the cost of the IVF or ART in general, and due to helping patients, especially in the old age group as well. So some of this characteristic, it is very hard to change, as we said, like the age ovarian reserve, whatever, but some of them, it is easy to change by changing the lifestyle and giving some medication or surgery. Now, if you went to the age, the chance of pregnancy by age affecting in natural conceiving and an assisted reproduction technique as well. For example, live birth rate per started cycle has declined from 32.8 of a woman aged 30 years old to 2% for somebody 45 and over, maybe. So it is actually big difference in the chance of pregnancy according to the age of the patient. And all of us, we need to understand that, because that will help taking the right decision and the right treatment for the patient. All of us, actually, we met many cases, she's 40, 42, and the gynecology or somebody actually start giving her clomid for years and year or month, and is coming to do IVF when she's 42 or 45, which is too late from our point of view. Basically, as the patient getting older, the chance of cancellation rate very high. So look at that, 50% in women, 50% in women, 50% women between 38 to 40, when comparing 17 or 18% when the woman less than 30 years old. Now, if you look at the graph, the effect of woman's age on monthly chance of pregnancy has come really down from 25% almost to 0 or 2% when she's 44 to 46. So the age actually a big significant factor by judging the result of ART. If you look at this data from the SART, American Society of Reproductive Medicine, look at the chance of pregnancy for single live birth. It is actually coming down for age, from 24 years old or less until 44. So the chance of pregnancy coming down, even the chance of multiple pregnancy coming down, and the live birth rate coming down as well. We did actually a very small study in Kuwait. I sent a questionnaire to the top hospital to see what is the idea of the gynecologist about the chance of pregnancy. We found about 10 to 15%, unfortunately, they don't know the chance of pregnancy for somebody over 45. If you look at this fourth line, actually, what are the chance of spontaneous pregnancy for a 45 years old woman and over with no fertility problem? The majority of them, they say that's about 10 to 15%. They say their chance about 10 to 20%, which is really not right. So we need to be aware about the effect of the age. So it is the age of the ovary equal to the age of the woman. It is not necessarily. Sometimes we start stimulation for somebody like 40, 41, and we get like 15 eggs. And sometimes, we stimulate somebody very young with premature ovarian failure, hardly we can get any egg. I mean, how we assess now the ovarian reserve? We have to do some biochemical marker and some biological marker, like AMH, basal FSH, and antral follicle counts, and plus the ovarian volume. Not everybody will calculate the ovarian volume, but we found that quite helpful, and we'll tell you why. I mean, for the AMH is basically glycoprotein. We don't want to go in details, but it does reflect the number of the follicle in very early stage. So basically, the difference between FSH and AMH is actually, you can predict who's going to have hyperstimulation. You can choose the right dose for the patient or personalized treatment, but the FSH can predict the poor responder, but never predict the over-respond or the ovarian hyperstimulation. So basically, AMH, more direct marker, usually produced from the granulosa cells, and reflect the preantral and small antral follicles between less than 4 to 8 millimeter, basically between 2 to 10 millimeter. It's actually more flexible in the time of measuring. We can do it at any time of the period. You don't have to do it day 2 or day 3. And the variation is very low, inter and intracycle variation, comparing that with the FSH. And all the changes in AMH happen very early before any changes in the FSH or antral follicles count, and even actually before the effect of the age. If you look at this slide, low intercycle fluctuation in the AMH. If you look at the other side, the FSH, so the FSH variation is really very high, and that reflects the intercycle variation. Even intracycle fluctuation is very high. Look at the FSH, the variation about 108% between like -25 of the cycle to 0 of the cycle. and the other one, the variation is very low. So basically, you can measure it at any time during the period, during the ovulation time, or any time of the period. And if you look at this scatter of the serum anti-AMH, this is actually from recent publication in July 2019. The green line, two green line, actually present the 25 to 75 centile is absolutely concentrating between age 25 to 40, and it's coming down after that. So the scatter is quite high in the age of reproductive life and become down in the late stage, or even actually low in early stage. So there's no benefit in doing AMH to assess somebody ovarian reserve in very early stage before 15 or 18 years of old. Now, the basal FSH is an indirect biomarker because produced from the pituitary gland. You can predict actually the poor responder, but you cannot predict the hyperstimulation. It's low reliability, as we said, and not very accurate to assess ovarian response or pregnancy prediction. And basically, we use the cutoff point 10.4. We used to use this cutoff point 10.4 when I was in Birmingham and Cardiff in UK. Some people, they use the cutoff point 11. Some people, they use actually 8. Some people 9. But most of the people between 10 and 11. It's, when the woman has a high FSH level, they have high chance of cancellation rate. That's means going to produce less number of follicles and less number of eggs, and poor success IVF rate as well. We did actually a study in Birmingham. We measured the FSH for 344 women, and Khaldoun Sharif did that publication. We found is a better predictor for cycle cancellation than the age. So if you have high FSH level, if it's more than 10.4, 70% the chance of cancellation rate, comparing with 17 or 15% with somebody with normal FSH and a younger patient as well. Now, the other one, the antral follicles count. Usually you assess antral follicle count by ultrasound scan. It is very easy to be done, especially with the new machines of ultrasound scan 3-dimension. We measure all follicles between 2 and 10 millimeters. Basically, it does not tell you the oocyte quality. It tells you the number of the oocyte maybe going to harvest on that cycle while doing IVF or stimulating for IUI. As you say, we measure the follicle between 2 to 10 millimeters. The number decreased usually with the age and reflect the number of the follicle going to harvest, as we said, in the cycle. This is the scattered of as well antifollicle count with the age. It's become, as I say, between the 25th to 27th, 75 centile is between the two green line. Now, the ovarian volume is quite helpful. When the ovarian volume, one standard deviation below the normal, the chance of cancellation rate 20%, comparing that with 5% with normal ovarian volume. In our unit, for example, we do something they call ovarian assessment scan. We do that for everybody going to go for IVF treatment, even for IUI stimulation. We measure the FSH, AMH, the BMI, the age, antral follicle count, and we write in the form how easy access to the for the egg collection. So we get all the information in this form, and very unlikely to do any egg collection before actually doing this assessment as well. Now, the second criteria, the cause of fertility. The live birth rate actually by diagnosis of the diagnostic category is very little actually. But the last data from the SART shows really big variation. If you look at the graph here, the chance of pregnancy 14.6 if somebody has premature ovarian failure or low ovarian reserve, and the highest ovulation dysfunctional like PCO. So the PCO, they have higher chance of pregnancy. Of course, they have higher chance of ovarian hyperstimulation syndrome, but still actually helpful to know the cause of fertility because it does give you how much the patient has a chance to conceive. Tubal factor important, but the most important, the severity of tubal factor. If somebody has hydrosalpinx, definitely has a low chance of pregnancy, but we need to distinguish the low chance of pregnancy with visible ultrasound scan hydrosalpinx. If the hydrosalpinx is not visible on the scan, that means it's not going to have big negative impact on the chance of pregnancy. Basically, we did the doing salpingectomy is quite effective, or clipping the tube. But when you discover that you have hydrosalpinx during the stimulation, and we don't know why some people with tubal factor, the hydrosalpinx will appear during the stimulation. Instead of canceling the cycle, you can do hydrosalpinx aspiration on the day of the TVOR, and that will improve the chance of pregnancy. If you look at the, for example, miscarriage rate with the aspiration group 28.6 and with control group 42%, it is really not significant, but actually it's clinically significant to improve the chance of pregnancy. So aspiration of the hydrosalpinx, a good idea, helping a patient with hydrosalpinx, especially if you discover it during the stimulation time. The endometriosis, we don't want to spend a lot of time on the endometriosis. I believe the endometriosis reduces, as everybody, the chance of pregnancy because you're reducing or dimension the ovarian reserve, because the patient having many operations usually. And the best advice for people who have endometriosis to go very aggressively with the treatment, either go for IUI, maximum 2 cycles. If not pregnant, you go for IVF. And the chance of pregnancy, of course, depends on the ovarian reserve, many factors as well, and the endometriosis stage 1 to 2 or stage 3 to 4. If you look here, the pregnancy rate is quite different from the control group. If you look at actually in the yellow marked or highlighted figure, you find a really big difference. Pregnancy rate 20.1 in the endometriosis grade 1 to 2, comparing with 27 of the control group. With stage 3 to 4, 13.8 to 27 in the control group. So we have to refer the patient as early as possible and have aggressive treatment for that. Now, the leiomyoma or fibroid is a really difficult subject to advise because you have to take each case as it is. But doesn't matter if you have submucosal fibroid, definitely you have to remove that. All of us, we agree. If you have intramural fibroid and less than 7 centimeters, that's not actually affecting the uterine cavity or bulging to the uterine cavity, you don't have to remove that fibroid. But you have to take in consideration the patient age. If somebody is 39 years old and has all this fibroid, and she has 1 or 2 cycle IVF, if not pregnant, definitely you have to remove the fibroid. And there's a new study, actually this is published recently, I think in 2010, by Tariq Al-Touhi and Yaqub Khalaf from London. And they say even if the fibroid did not destroy the uterine cavity, you have to remove it to improve the chance of pregnancy. But this is comparing control group, no fibroid, with a group with fibroid. This meta-analysis actually is about 6,086 or 89 cycles has been reviewed, and they found still there's a negative impact on the pregnancy rate if you have intramural fibroid did not affect the uterine cavity. As well, you have to take in consideration, balance the benefit of the surgery and the side effect. And we are not quite sure, even in this study, if you remove the fibroid, are you going to restore the fertility or have the same result with the control group? We don't know because you don't know the effect of the surgery in this kind of cases. But generally speaking, if you have a big fibroid with recurrent IVF failure and you don't have any other reason why the patient not getting pregnant, I think advisable to remove the fibroid, especially in the old age group. Now, as the duration of infertility getting longer and longer, the chance of pregnancy less and less. That's what secondary infertility have better chance than primary infertility. And if you look at this old data, but this is the only Templeton data in the literature, when you analyze the data from the HFEA and found if it's actually low duration of fertility, like 1 to 3 years, 15 chance of live birth rate, but it's come almost 8% when they are more than 10 to 12 years duration of infertility. I mean, if the patient had pregnant before, she has better chance, as we say. I mean, this is the first, outcome of a second cycle after pregnancy in the first cycle. If the first cycle ended in successful pregnancy, the chance high. If it ended in miscarriage, about 31.5%. And if it ended ectopic pregnancy or biochemical pregnancy, will be low. Even if the patient had in the first cycle biochemical pregnancy, that means she has a better chance next time than somebody never get pregnant. Now, rank of the IVF attempt, the chance of pregnancy in the second, third, fourth cycle become, going in the graph up, But after 4 or 5 cycles, the chance of pregnancy go down. So if you compare this is actually IVF cycle. They never get pregnant in the previous cycle. When there's no previous cycle, look, the pregnancy rate very high. So this is from the first cycle. People with 1 previous cycle, the other color is slightly low, 2 previous cycle lower, and they have 3 or more previous cycle, the chance of pregnancy even low. But the cutoff point between 4 to 5 cycle, if it's getting more than 4 or 5 cycle, the chance of pregnancy definitely less. I mean, I don't want to talk too much on the obesity. All of you has effect on the IVF and chance of pregnancy. And always there is morbidity and mortality on pregnancy during delivery, and effect on the baby, and diabetic, gestation diabetic. When the waist-hip ratio over 0.8, the chance of pregnancy is reduced from 29 or 30% to 15%. So you have to advise the patient to lose weight. And this graph actually shows very clearly the big difference between the first BMI less than 18.5 and BMI over 50. Smoking, it does affect the sperm capacity of fertilizing the eggs and affecting the eggs quality as well. So you have to advise the patient stop smoking. And to have the maximum benefit, you have to stop the smoking 3 to 6 months before IVF cycle. I mean, there's a study from Hani Lashen in Birmingham. There's no difference in the ovarian stimulation between Asian population and white, Caucasian white. But there's another study recently come in December, I think 2018. So it's big difference between stimulating Asian population and Caucasian population. Now this is the clinical aspect. The clinical aspect actually very significantly in IVF success rate. It is actually different from center to center. For many reasons, this is affected by the embryology, by the clinician, number of the cycle they do, the selected of the patient, and some of them, the way they cancel the cycle. Some center, when they cancel the cycle, they don't include it in the statistics. Some of them, they include it. But unfortunately now, in UK, for example, HFA forcing people to report the cycle properly, and you have to do that online. Now, stimulation protocol important. We are not going to go to the simple stimulation for IUI or control ovarian stimulation, but you can choose, either conventional gonadotropin therapy, you need to give high dose for treatment, or low dose using recombinant FSH. Of course, different protocol for that. Our goal to have singleton pregnancy, reduce the chance of having cycle cancellation or HSS and multiple pregnancy, because this is a complication. I mean, we don't want somebody to get pregnant and ending 3 or triplet in the incubator, costing the government a lot of money, and in the end ending cerebral palsy. Now, that's what actually using recombinant FSH, it is much better than the bioassay component, because the variation quite low. And if you notice, actually, the recombinant, actually, you have fewer cancellation rate, 70% less cancellation rate. So less vials, less cancellation rate, and you have actually the privilege of using PIN. Even you can use actually increment by 12.5 unit. So even you can use a recombinant for control ovarian stimulation, IUI and IVF. And I think the date of using bioassay and urinary FSH is gone because the side effect of it and the accuracy using recombinant. And I'd say 31% lower in the dose for IUI cycle and less cancellation rate. Even the costless, actually, we did analysis for meta-analysis in Birmingham in 2000, and we found the cost for a baby with recombinant FSH, $700 less than using urinary FSH. Now, the other factor, number of embryo transferred, if you notice, this is from the HFA statist, or actually data, the number of 1 or 2 embryo transferred going up, and the date we used to transfer 3 and 4 is gone. Even the chance of pregnancy from day 2 and from day transferring 1 or 2 embryo from day 3 and day 5, almost the same, and even better for transferring blastocyst, single blastocyst on day 5. Now, embryo cryopreservation program important because when you look at the pregnancy rate or chance of pregnancy, you don't look for the IVF fresh cycle, you look for cumulative cycle. And the cryopreservation program important to increase the cumulative pregnancy rate. The number of XC cycle, as you notice, this is from HFA as well, is IVF less and XC more. And is this unnecessarily because the chance of patient either in poor responder which this is, they say, poor responder, you have to use ICSI. Even poor responder, the IVF better result. There's something, what should we add? I mean, only 2 minutes, I'll finish, 1 minute or two. There's some people, they say, what actually the adds-on procedure help? You know, many add-on procedure in the IVF lab and the IVF clinic, everybody's claim it's actually perfect, improving the chance of pregnancy. There's some of intervention, there is no any growing evidence, like endometrial scratching. It does help when you have recurrent IVF failure. It does not help doing it from the first cycle. Like time-lapse imaging is no any evidence. And 56% of the UK center they're using it. And hyaluronic acid is no evidence. Elective freezing for embryo has become a trend now. Doing egg collection, freeze all the embryos because the patient requests that or because she has hyperstimulation. Even that actually is not necessarily. And if you look at the other, like intrauterine culture, no any evidence. Assisting hatching, no any evidence so far. Even sperm DNA fragmentation, limited evidence. And transferring mitochondrial DNA, no any evidence as well. So we need to conclude what has been said. At the beginning of the treatment, couples should be informed about their chance of pregnancy, and you need to tell them their chance, how much their chance from IVF pregnancy or ART comparing with natural chance or natural conceiving, the major factors affecting pregnancy and live birth rate, the age, and the rates of pregnancy decline after the age of 38. Increasing duration of fertility is an important factor. It does affect the chance of pregnancy, previous pregnancy, and the most important, previous live birth rate improve or actually a positive value for next IVF cycle. Ovarian reserve is a very useful predictor of successful ovarian stimulation and IVF outcome, and it does help you how to personalize your dose for treatment or segment your patient like low responder, normal responder, or over responder. So the presence of hydrosalpinx significantly impair the chance of pregnancy. Either you have to do salpingectomy or clipping the tube or hydrosalpinx aspiration. Thank you.
Thank you very much, Dr. Hamada.
Thank you.
For this comprehensive view of infertility. Of course, I'm not an expert on fertility, but we have 3 minutes for questions, please. Moza, please. The mic to Dr. Moza, please. Dr. Moza Rashid.
I must thank you very much for that very nice, informative talk.
Thank you.
I just want to know your view about the future use of stem cells in patients with poor ovarian reserve.
There is a big, actually, debate or it's a controversial issue now. There's no any significant that we can help reproductive area in the stem cells, but there's many research going on, especially with Peter Schlegel in New York about stem cells with azoospermic patient to basically implant the stem cells in the testicular tissue and produce the sperm with azoospermic people. And for premature ovarian failure, there's a lot of study going on now, but still there's no any evidence. People, they try to inject stem cells or try to improve the ovarian preservation, especially somebody like 45 with FSH 50 or 60, is absolutely no any evidence. And it's very dangerous. I got a patient from Turkey recently, they inject for her actually some platelet and stem cells. She came with severe pelvic infection, stayed in the hospital for 10 days in the intensive care unit because she has septicemia. So you have to be very careful using these things now.
Okay, thank you very much. This is the last question, please, Dr. Hafsa.
Good afternoon. Thank you, Dr. Nahat, for this informative lecture. Regarding the AMH, do you routinely do preliminary part of the preliminary investigation AMH? And do you agree with any patient came with less than 35 years with low AMH to go direct for IVF, or how you will counsel this kind of patient?
Sorry, Hafsa, I understand the first part of the question.
Do you routinely doing AMH for all the patients?
The other part of the question.
And the second thing, if you get a patient who is less than 35 years with normal ovulation, normal sperm count, apart only from low AMH, do you counsel her regarding going direct for IVF? How you will approach this kind of patient?
Thank you for this nice question. I think basically I do AMH routinely, but you have to be very careful. When you do AMH, it must be in the same lab for all the patients because it's really different from lab to lab. This is issue. And we have a problem now. Most of the hospital I'm practicing now in Kuwait, we send the AMH to London to assist with some of the lab in London. Sending this actually sample to London, it will be affected by the temperature. They claim no, but definitely affecting that. Now, I don't use it as the only assessment for the ovarian reserve. If somebody has antral follicle count of 25 and the AMH 3.5 and the range up to 50, I will not take it really in consideration. That's a big factor, because if you do Fourier stimulation, you produce a lot of eggs. But what I will do, to take many factors, ovarian volume, FSH, antral follicle count, AMH, and then take the decision. But if somebody, so basically I do it routinely. If any doubt, either I repeat it again or I take the other factors to assess the patient. Now, if somebody is quite like 35 years old with very low AMH and has no children, I think it depends how long she has been trying. If you're trying for 1 year or 2 years, I'll try one IUI with her. The IUI will give me information about hair stimulation. If we did IUI and it's very good response, then no point to do IVF. We'll leave her a bit longer and we can do IUI or control ovarian stimulation. But if the response is not very good, then I advise her for IVF, yes.
Okay, thank you very much, Dr. Hamada. Thank you.
Thank you.
Okay, we carry on with urogynecology now. We are 10 minutes late, but hopefully we can make this during the sessions. I'll call on the next speaker, a long-life friend, colleague, Professor Stefano Salvatori from San Raffaele Hospital, Milan, Italy, to speak about safety and efficacy of mesh repair for pelvic organ prolapse in 2020. Professor Salvatori was the past president of the European Urogynecological Association.
Mr. Chairman, ladies and gentlemen, good afternoon, and thank you for inviting me at the first International Congress of Obstetrics and Gynecology in Bahrain. It is my great pleasure. I cooperate with Professor Risk for a long time in clinical and research projects, and once again, it's a great honor for me to be here. Over the next 20 minutes, I'm going to give you a sort of history of what is happening regarding the use of meshes in reconstructive pelvic surgery. This is not an easy time. It's not an easy time for a condition that is quite common, as we well know. Prolapse is a very common condition with a lifetime risk of having an operation of 11% and with a recurrence rate of 29%. 10 years ago, we've got data from US where 300,000 operations were performed. In a third of cases, a mesh was placed, and in 25% of these cases, the mesh was placed transvaginally. Why mesh? Because even in the best hands of the best surgeon, like Professor Schul, that performs vaginal surgery, we pay a rate of recurrence. And this is particularly true for the anterior vaginal compartment. And the mesh concept is, in a way, copied by what happens in general surgery, where surgeons place mesh to repair hernia. And basically, with the same concept, considering prolapse as a sort of hernia, gynecologists decided to use meshes to reinforce or substitute the supporting tissue. Now, I have to declare that I have not been very much in favor of meshes in general, because I had a very bad experience initially with my mentor, Professor Milani. I think that for the first time ever, we published in the BJOG in 2003 the first report where the use of meshes determined an increase of dyspareunia when they were placed in the posterior compartment. And we know that things have changed since the FDA delivered the first warning document in 2008. And as you can see, since 2008, worldwide, these are market data, there was a decrease in the use of meshes that had some ups and downs, depending on what happens in the literature. But basically, it followed a constant decrease. Certainly, one of the most important papers that supported the use of mesh was this one by the group of researchers from Sweden, Norway, Finland, and Denmark that was published in the most prestigious journals in medicine, the New England Journal of Medicine, where more than 380 women were recruited. They were randomized for mesh repair versus native tissue repair. 53 hospitals were included, and that makes you think in a way regarding, let's say, in a way, the reproducibility of the procedure, because basically less than 8 procedures were performed in each single unit. And sometimes, if you want to be the devil's advocate, you may wonder about the training of people when you see something like that in the evaluation. That is basically when we did the POP-Q system, they scored some points in the POP-Q with values that are not possible, they are not accepted in the POP-Q evaluation, like minus 4 for the AA, or minus 7 for the BA. By definition, no point can be negative with a higher value of -3. We wrote a letter to the New England Journal of Medicine pointing that out. That was not in a way published, but that is a mirror of, in a way, at least an inappropriate way of evaluating the patient. But nevertheless, looking at what they consider the success parameter and the primary outcome, they found that was basically no prolapse or stage 1 without being symptomatic. They found that women who had meshes were significantly more cured than patients with native tissue repair in a very high significantly way, as you can see from this slide. And they concluded that mesh was supported and that we should use mesh also in primary surgery, regardless the higher rate of complication. And as you can see here, significantly higher complication for stress urinary incontinence, for duration of surgery, for intraoperative blood loss, for bladder perforation, inguinal pain, and bladder voiding symptoms. Now, I think that in real practice, actually, the situation was different. And as you can see from this slide, at least in academic units in US, there was a constant decrease. Unfortunately, the laser seems to work, but there was a constant decrease of the use of meshes, surgical procedure, with an increase in the surgical procedures done to remove partially or totally the mesh that were placed for reconstructive surgery. Then in 2016, the FDA delivered another document raising the risk of meshes to class 2 to class 3, consider them therefore at a high risk, and requesting from companies pre-marketing data for safety and efficacy. In Europe, we were more tolerant, and I think, as the old Latin population said, the truth is in the middle, it's not black or white, but at least we should try to consider mesh just in complex cases after failed primary surgery. And this should be done in tertiary referral centers in cases where we expect native tissue repair to fail. European authorities encourage also scientific society to provide certification of competence for surgeons. And I think this is a crucial point worldwide. There has been, I would say, a reduced training program for vaginal surgery worldwide. I had a chat with the actual president of the American College of Obstetricians and Gynecologists. They have the same feeling in the US. There are less and less people that are trained completely for native tissue repair done vaginally. What about Cochrane review? Well, for Cochrane review, we know that in terms of biological graft, it doesn't seem to help compared to native tissue repair. But when we talk about synthetic graft, certainly the one who places synthetic graft in the anterior compartment has less likelihood to develop at least second stage of recurrence in the anterior compartment compared to native tissue repair. Despite, for the first time ever, the Cochrane reviewers make a difference between the isolated anterior compartment or anterior compartment concomitant to the apical compartment. Where the anterior compartment alone is considered, mesh seems to work better. When there is a multi-compartmental defect, mesh doesn't seem to be superior to native tissue repair. The Cochrane review confirmed that women who are submitted to mesh repair are more likely to develop stress incontinence and to be submitted to stress incontinence operation. And what they summarize is that, as you can see here, that mesh can be used in specific condition by good surgeons and counseling the patient appropriately. There are more and more data coming out, pro and cons meshes, at least in specific cases, and also scientific societies are now, in a way, delivering more and more recommendations and position statement. But certainly this paper published in The Lancet in 2017 is quite an important one, because it's on more than 18,000 women for a period of time of 10 years, for women who had native tissue repair and mesh surgery. They considered a huge amount of variables, and the conclusion of the authors were that for prolapse, the use of mesh is associated with increased risk of complication and low effectiveness than native tissue repair. So this is a very strong sentence in the biggest registry that has been published so far. We've seen already this data from Professor Risk this morning. There is this study that is a longitudinal health claims from 2005 to 2010 from Funk, that basically calculated that the repeat surgery was significantly higher for vaginal mesh versus native tissue repair. So once again, I'm not against meshes, but we should try to understand when it is advisable to use them, counseling the patient with all the data that we've got available, and in a way trying to do this procedure in selected units. When we have a mesh complication, we should also decide what to do, keeping in mind that if we remove totally the mesh, the risk of recurrence is significantly higher than if we remove the mesh partially. And in my experience, when we remove the mesh totally, because, for example, it is infected, it's not advisable to do a concomitant procedure of repair at the same time, because the tissue are so damaged that they wouldn't sustain the prolapse anyway. Now, we've seen what is available in literature, and in 2017, the European Association of Urogynecology, together with the European Association of Urology, delivered a joint position statement that certainly was more tolerant compared to what was available in the US. We thought that we could use meshes, but in complex cases, with recurrent prolapse and in specialist referral centers. And that is what is happening actually in UK, where they are now, in a way, selecting the units where mesh could be removed or where mesh could be implanted. So in recurrent cases, but which is the dimension of recurrency? Actually, the reoperation rate for meshes, looking at this study on more than 18,000 women, is 11.5%, and it is age dependent. If a woman is premenopausal, the risk of recurrence is more than 25%. If a woman is postmenopausal, for some reason that I would think intuitively the opposite, but it's actually less. It's 10 point something percent. Again, this is another study, the retrospective study on more than 200 women that was published in the Blue Journal, comparing transvaginal meshes versus native tissue repair. And the authors showed that there was no difference in the total reoperation rate between the two groups. This was one of the studies that was included in the revision of the ICI committee for prolapse surgery, that as Professor Risk mentioned before, it's a group of experts that in a way review the literature every 3 years and give the level of evidence. And the conclusion of this committee, you can see in this slide basically, that this is the last a document of the ICI. The risk-benefit profile of transvaginal mesh is compared to native tissue repair for recurrent vaginal prolapse is similar to primary prolapse. And this making doubt what we delivered as the European Society too, except for higher rate of mesh exposures than reported after primary surgery. So we cannot conclude anything about the use of mesh in recurrent prolapse. There are too poor data. We should do more studies on the use of meshes also in high-risk patients for recurrence and in recurrent patients. I think that at the moment, if we want to use mesh, because sometimes we don't have other choice, this statement that comes from our Yuga committee, where also Professor Rizk is included, is that we should counsel our patient properly. We should let them know what we have available in literature, which are the best results that we can get in our hands with the limits of the procedures that we've got available, and what mesh can do to help or what mesh can do in terms of adverse events. But certainly as scientific society, we should try to raise our efforts to monitor what we are doing. And I really like the initiative of the American Urogynecological Society that in conjunction with the FDA has promoted a national registry. I think that that should be mandatory, that should be compulsory in any country. We are fighting in Italy to try to convince the Minister of Health to have a compulsory register for anything that is placed in the human body, particularly for prolapse and incontinence. But to make things even more difficult, on the 16th of April 2019, the FDA almost killed the mesh. They basically invited all the manufacturers and distributors to withdraw any product that was available on the US market for prolapse repair. This is a use document that not necessarily reflects the truth and not necessarily is applied worldwide, but certainly have at least in Italy for our legislation some medical legal implications. If we have an operation, despite the fact that the European guidelines or position statements support the use of mesh, with that document some lawyers may have an easy task for their job. But what we have for future, what is in the crystal ball of desire? Well, actually there are a lot of researchers that, and companies also, and I'm a very strong supporter of the transparent cooperation between researchers and companies. They are developing new graft materials, and there are a lot of research on regenerative medicine and tissue engineer. There are more and more data on stem cells in the use of prolapse. As you can see here, there are preliminary data in animals or at the moment. The use of PRP also for prolapse repair, and new biomaterial are now on the process to be developed. So what about the future? Again, I've been very lucky. I had fantastic mentors that were very strong supporters of native tissue repair, Professor Cardoso, Professor Rodolfo Milani. I had the opportunity to operate together with Professor Rizk, with Professor Schull. I think that we should not leave tradition, and that tradition and technology should go hand by hand. We should keep our competence in the classical reconstructive surgery, add something, regenerative or new tissue or whatever, but particularly now we should try to apply and talk with our patient, and we should try to apply the X principle, that we should listen and talk to patient to understand the expectations, to settle the goal that we want to achieve, and to understand what is satisfactory for our patients. That is not our vision in terms of normal anatomy, but in terms of vaginal function. Thank you very much for your attention.
Thank you very much, Professor Salvatori. Professor Abubakr Mardi will lead the discussion now.
Any question? Any question from the audience?
Questions?
Dr. Ayman?
Much for your very comprehensive presentation, and I really agree with more or less 99% of what you said. However, don't you think that some of the data that is accusing mesh didn't take into account that mesh itself has developed over the years, and they cumulatively didn't take account the change of mesh technology, like the weight, the weaving, the pore size, etc. So most of the data is coming from a collective sort of patient that can give an element of bias. The other issue as well, and that's from my own current practice, I do audit my patients for over 10 years, is that the recurrence rate is not only related to the surgeon or what have you performed, it's how did the patient behave afterwards. No studies had looked at how much precipitating and predisposing factors remained on those patients who developed recurrence or developed complications.
Thank you very much for your questions. Well, for the first part of your comments, yes, you're right. There are many data in the literature that are, in a way, reporting safety and efficacy rate of completely different products. If we think about what we were using in 2003, it's certainly completely different from what we're using now. But this is a mistake anyway. Despite the data, I mean, you can comment about different products and the data are there anyway, but this is a mistake that has been done by the ones who should regulate everything, that are the authorities, the scientific societies, and ourselves as physicians. I remember that in 2007, the American College of Obstetricians and Gynecologists delivered a warning regarding the validity of an informed consent for mesh repair because of this dynamic market that was continuing changing. In other terms, how can you ask a patient to consent for a product that has just been launched where no data are available, and which is the value of that? I remember a couple of years ago in ICS, we had a sort of face-to-face between Professor Domokowski and a lawyer. And Professor Domokowski, believe me, he's an extremely experienced person. The lawyer killed him. I mean, you don't have way out. You don't have way out as you are organized. And I think that Professor Risk mentioned today that the ICI and also the ICS 2 or 3 years later suggested, unfortunately it cannot be mandatory, but suggested that for the introduction of a new surgical procedure, we should wait at least 5 years to put it on a broader scale in order to consider it safe and effective. So yes, it's true. In literature you can find everything, but despite the results are quite similar anyway, I think that it is fault of everybody, and we should try, as urogynecology, to use meshes in clinical trials if there are new kits. Scientific societies has, and this is a j'accuse that I do, should strongly be more determined in giving rules for new procedures. In Europe now there is this new trend for laparoscopic lateral suspension with a mesh with basically 5 papers in the literature. And I keep on removing meshes because of pain or because of retraction of the mesh and recurrence also, and well, we will report it, but this is a procedure that is still performed on a large scale in Italy and in France. So there is a lack of regulation, and we should do something. The second question regards the recurrence perception. Is that right?
I've seen patients who had chronic cough, and you've put mesh and it came back. Well, you didn't treat the chronic cough. Putting weight on, getting pregnant, lifting. A lot of other patient-related factors we as clinicians fail to address pre- and post-operatively, and these could be detrimental to the outcome.
I totally agree. I published a paper in Urology and Urodynamics on the risk factors, and there are patients who are at higher risk, and the ones who chronically increase the abdominal pressure, the obese women, but also the most severe cases. I mean, the more severe is the prolapse, the more likely is to have a recurrence. But we should talk with the patients also regarding this aspect.
Just one quick one. Remember that the last data in Professor Salvatore's slides about the recurrent prolapse. I was discussing primary repair prolapse, completely different. Primary prolapse versus recurrent prolapse. Do you use mesh or not? Yes.
Professor, any more questions? Thank you very much for a lovely lecture. May I introduce my colleague, Dr. Ayman Naga. He's a senior urogynecologist. He's the head of urogynecology in Hamad Medical Corporation. Dr. Ayman was a senior lecturer at the University of Birmingham. Ayman.
Good afternoon, everyone. Assalamu alaikum. I would like to thank the organizing committee for inviting me to join you today in this very well-organized meeting. Now, before I start, the title of my presentation is Recent Advances in the Management of Overactive Bladder. And I have to say, it's a challenge to try and do this in 20 minutes. The word management really should cover all those elements, from history, examination, investigation, understanding pathology, treatment, and follow-up and support. And that could, we've done 2 or 3 days symposium just to cover that topic. So I'll try and do my best to cover some of those elements. Urgency and frequency causes, you can see there's a big list of causes that you really have to exclude before labeling a patient that she's an overactive bladder. I've highlighted here the detrusal overactivity because it's a urodynamic diagnosis where you find a detrusal contraction. However, more or less, the approach to the patient is exactly the same. Now, overactive bladder, a lot of us do not see it as a disease. However, you can see from this slide that it's only second to depression in affecting the quality of life. It supersedes diabetes and hypertension. So really, it is not something that is simple. And I've seen patients with ruined lives because of overactive bladder. Now, that is the main question. Can you hold? Now, that's actually important, especially in women, where urgency is one of the main factors in the symptoms profile, whether that is associated with urge incontinence, with frequency or nocturia, but it is the central driver for most of the other symptoms. Theories for detrusal overactivity. If you're originating from the detrusal, that's the current concepts. It could be of a neurogenic origin, whether central or peripheral. It could be of a myogenic origin. However, the urothelium is emerging as a main source of dysfunction that can lead to overactive bladder. This is just a schematic presentation of the urothelium. And it's not just only a barrier. It does have actually a natural antimicrobial function. It's a dynamic for solute transport, and it does secrete a lot of neuropeptides, neurotransmitters, and this is the basis for most of the current developments for treatment of overactive bladder. The concept of the non-adrenergic, non-cholinergics is now proven to be a concept because why, when you give a medication that's meant to stop acetylcholine, works on some patients and don't work on others? This suggests that actually the non-adrenergic, non-cholinergic pathway could be involved. Now, we all have the understanding that it's because overactive bladder could represent a detrusal contraction. However, actually, a lot of the patients, if you're going to label them overactive bladder, they do not have a detrusal contraction demonstrated on a urodynamics, and there is evidence to support that some of this issue is related to a sensory input rather than to a muscle problem. So urothelial function remains protective, but also it's a very strong sensory organ. When we go on to the treatment option, you can see here I've put a slide that more or less summarizes all the treatment options, but I've highlighted the main elements that I'm going to be covering, mainly anticholinergics, the new developed beta-adrenergics, electrical stimulation, neuromodulation, and interruption of innervation, different modalities. Now, I came to the Gulf and I practiced in Doha only in the last 4 years. But believe me that it was an eye-opener when you speak to women from this region about what kind of treatment acceptability they are willing to actually embark on. This is a study from Robinson et al. In the UK, and that's in Western, obviously a British study. And you can see that patients have less chance to accept any treatment that either for life, that can involve catheterization, even with a higher success rate. And I can tell you from my own experience that the ladies in the Gulf area, due to our background, social and religion, they look, once you were intermittent self-catheterization or lifelong treatments, they look at you with horror. So keep that in mind when you're trying to treat patients. So from a clinical point of view, we normally have a 3-tier system in approaching patients with overactive bladder, starting by fluid management, bladder training, with or without pelvic floor exercise, and you try and do that for a good minimum of 6 weeks. The second tier is in the form of oral anticholinergics or even the new beta agonists. However, we know from experience that the side effects lead to discontinuation, and definitely more than 50% by the end of the first year of treatments. The third tier involves some surgical options, including sacral neuromodulation, intravesical Botox, and tibial nerve neuromodulation, and I will show you that in a minute. So come to the drug treatment. What is the desirable drug? And this has been a challenge of having a specific with maximum efficiency dose, something with side effects. Now there's a really great fear and worry about the cognitive function, especially in the elderly. Now we know that with the increase of life expectancy, a lot of your patients will be in above 60 group, and this is becoming a real worry. How to enhance the patient compliance, how to control the administration of a therapeutic dose that could be maintained. These are more or less a comprehensive list of all the medication available in the UK of anticholinergics. And they share very common grounds. The side effects mainly dry mouth, constipation, blurred vision, and somnolence. However, when you look at the more detailed comparison, you can see some of them are quaternary amine rather than tertiary amine, and some of them have a minimal hepatic metabolism, and that's very important for patients who have a problem with their liver function. So before deciding which anticholinergics you're going to use, don't just look at how they work, but look as well when you look at data saying how much effective they are. You can see from this slide that depending on which outcome measure you're looking for, some medications are very good regarding the frequency, some medications are good regarding nocturia, other increasing the volume. So they are not all having the same end result outcome. And that is a good thing from me as a clinician, that I can actually use something different depending on the patient. However, that's not only enough. You can see from this slide again that the side effect profile is completely different. So, for example, something like darifenacin or the trospium, who do not close the blood-brain barrier, are very good options for the elderly if you have fear of cognitive function. However, they might be something notorious for constipation like darifenacin. So the message that I'm trying to get across is that tailor your treatment to your patient. One of the problems, again, because of the hepatic metabolism, that delivery system could have been improved, and definitely one of the medication that has more or less stood the test of time is oxybutynin, but is notorious for side effects. However, these side effects can be ameliorated to a great extent once you change the delivery system, and by creating a transdermal patch, we had a very good response in some patients. Again, another modification of the delivery system using a gel, and that have been actually shown to be quite acceptable in patients who had a good response but couldn't maintain the treatment because of the side effects. Toviaz is a derivative of tolterodine, and it's unique in a way that it does not have a hepatic metabolism. And again, that could be very important in patients with hepatic dysfunction. This is an outlier, the desmopressin. It's a designer medication. It does have an antidiuretic effect and might have a role in very selected patient group who suffer from nocturia, or could be as a designer use on as need basis. However, you have to be careful with your electrolyte imbalance, and you have to check your sodium levels. Beta-adrenergic agonist. The first beta-adrenergic agonist came back in 2013, and that was an eye-opener because it had a far better side effects profile compared to the anticholinergic. However, that is still giving you the cutting edge. So mirabegron, it's in a 25 or 50 milligram daily dose. Now, by the end of this year, a new medication called vibegron has shown that it does have a significant impact regarding voiding volumes and nocturia, with a comparable, if not better, side effects. This medication is something new, and again, it's one of the modalities that we've seen. Cutting-edge developments. So what happens when you are running out of choice? So some of now using combination therapy. You cannot use two anticholinergics because of the side effects profile, although some patients would have responded. But we can use two modalities of medication, like the beta-mimetics and the anticholinergics. There's new evidence of using an anticholinergic and a cholinergic medication, so it's an agonist-antagonist effect, or using another class of medication like an anticonvulsant. The FDA, only 2018, approved the concomitant use of mirabegron and anticholinergics. Again, the combination of tolterodine and pilocarpine, which is a salivary stimulant, reduces the side effects of dry mouth. Again, tolterodine, the long release, has been tried recently with pregabalin, an anticonvulsant, with very promising results. The new frontiers, which are still in the development stage, you can see from my first slide about the function of the sensory elements. You can see a lot of these sort of modalities are being explored: calcium antagonists, nitric oxide donors, purinergic regulations. So I think that in the next maybe 5 to 10 years, we might be listening to a completely different sort of variety of treatments. General consideration for drug medication generally, it's each drug should be tried for a minimum of 4 to 6 weeks. You titrate the dose to a patient. If one drug is not beneficial, try others or combine therapies. Placebo effect is very high. Overactive bladder is a relapsing and a remitting condition, and I believe you have to counsel your patient that it's not a condition that we can cure you from. Pre-2000s, if you failed with medical treatments, you really had these horrendous options. to offer your patient. And we know that it's quite a morbid options with significant complication and significant repeat surgery rates. So here where it comes two main, the third tier level treatment options, which in the form of intradetrusal Botox. And we initially thought it's mainly myogenic, so it blocks the neurotransmitter responsible for a contraction. Most of the experience was for neurogenic bladders. However, in the last few years, it's emerged that it can actually work in patients with overactive bladder. And it works by binding the intramural synaptic glycoprotein, and it does stop the release of presynaptic acetylcholine. About more recently, it's shown that it does work on a sensory level by stopping the purinergic receptors. This is just a slide to show you the mechanism of action. How do we use it? It's use it by using 100 to 300 units. Nowadays, we moved away from the higher dose to try and reduce the rate of clean intermittent self-catheterization afterwards, and we use mainly 100 units for overactive bladder. The high dose is reserved for the neurogenic bladders. This is how we actually inject through a cystoscope in different sites. Recently, we thought that we deliver the Botox to try and reduce that through what we call a liposome medium, and that reduces the chances of having urinary tract infection and as well avoiding dysfunction. So this might be coming very soon. Neuromodulation. And basically you're trying to reverse the pathological signal at the level of the sacral nerve by stimulating the sacromotor system through the gate theory. I'm not going to dwell much on this, but basically it started with the neurogenic patient with a spinal cord injury, and that is seeing a higher rate of development. So you can see that even with the current system, it's expensive, it does need a lot of review. Now it's coming to the market probably to the end of this year. They've concluded as a very smaller device with a battery life expectancy of after up to 15 years. And the other issue as well, you can take the patient through an MRI machine if needed. Posterior tibial nerve modulation, and that's an alternative, less invasive to sacral neuromodulation. And we started by putting a needle in the patient's medial malleolus above it, and she needs to come for 12 weeks for half-an-hour session. That's become inconvenient for patients. So they went for two new developments. One is actually self-administered at home through a transcutaneous wireless stimulator. And the newest module of this just is coming probably the end of this year, which is basically an electrodes or that could be placed like the subcutaneous contraception, and it's a wireless ankle pad. The patient can treat herself at home. And some of the studies reported a 50% reduction of incontinence and leaks. And there's no severe, reported outcome so far. We're still trying to get the neuromodulation, so they're talking about direct subudental nerve stimulation or dorsal genital nerve stimulation. The latest devices, really, this is something is going stage 1 and 2 trial, is radiofrequency ablation to the bladder through a cystoscope using a catheter. This is showing very promising results and might bridge the gap. Stem cell therapy is always going to be in the forefront in every aspect of medicine at the moment, but this is very early stages in overactive bladder. So my conclusion, that we need to change the perception of the disease from an acute to a chronic model if you're going to consider it a disease. Potential to tap into the cognitive behavioral therapy, because we know that the placebo effect is high and there is a lot of psychological backgrounds. Not all patients tolerate pharmacological management, and neuromodulation and botulinum toxin have a role in refractory patients. The new family of overactive bladder medication, the beta-3 adrenergics, are new and reshaping the treatment alternatives. Anticholinergics will remain for the time being the mainstay, but you really need to consider the different types of forms of delivery and extended preparation. And at the end, what we try here is not treat a disease. We're trying to give the patient their dignity, their confidence, and their social acceptability. Thank you very much.
Dr. Ayman, thank you for a very eloquent, well-researched the area of overactive bladder. I think it deserves another clap for everybody.
Thank you.
And I open the place for questions.
Dr. Rima there, please.
Thank you for this enlightening presentation. I just have two questions. Regarding the women with overactive bladder, I mean, does it come at a certain age? Is it like after menopausal women more frequently? Did you look into that, or is it at all ages in women, basically?
I have to say that my own experience, you do get a peak following the menopause, but I wouldn't classify them as overactive bladder. Okay. It's a symptom of urgency that actually comes and goes, not persistent. And this is the ones which kind of a urethral type syndrome, and you actually give them some estrogen, and they actually will respond to that. Okay. So this is why I've put the causes of urgency. Okay. And I think if you can find that it's related to the lack of estrogen, it does not fit the criteria of being an overactive bladder.
Okay. Just another question regarding the beta-3 agonists. You said there are potential treatment strategies now. But what about, do they have cardiovascular effects, side effects?
Yes. Obviously, like I said, for the constraint of time, I couldn't go into details, but obviously being a beta mimetic, it's mainly hypertension and constipation. They still are reported by the beta mimetics. However, again, if you have a patient who do not suffer from hypertension, or you monitor her blood pressure, then actually they will become very, very good. I've seen patients, for example, you give them with a high dose of anticholinergics, and they respond excellently. However, they come back and say, well, I cannot continue that forever. Yeah. You reduce the dose to 5 milligrams, for example, or half the dose, and you give them a beta-3 mimetic, and some of them are actually quite good with that. The alternatives is the ones which I currently use. I use beta-3 mimetic as my first choice in women above age of 65. And I have to say, so far, if I'm in doubt, I send them to the physicians to monitor their blood pressure.
Thank you.
Thank you.
Any more questions? Dr. Ayman, thank you very much.
Just a quick cheeky comment. Of course, we like Dr. Ayman, but we give him the most difficult topic in urogynecology. And he's quite volunteer to give this, by the way. Okay? But this is not a punishment. This is, I think, trust in his abilities to give this most difficult topic in pharmacological therapy of urinary incontinence. Thank you. Okay, the next speaker is Dr. Abu Bakr Mardi again. Of course, you all know him from the morning and from the workshop, Penile repair yesterday. He's going to talk about another very hot topic, evidence-based management of female stress urinary incontinence. Dr. Abu Bakr, please.
And you can see from that I have changed the topic, and I have a very political title, the political landscape shift in the urinary stress incontinence management. And I have to declare that there is 3 documents which helped me a lot in talking about today. The European Society of Urology, the Canadian Society of Urology, and NICE, the International Clinical Excellence in the United Kingdom. This is where I work. I still work down there. I don't know if I go tonight, they may accept me or not. I have no any conflict of interest. And I think we still believe that the definition of an incontinence, which generated by the ICS in 2002, that's a complaint of any involuntary leak of urine. In one big study done by Paul Abraham and Nitti, in a mean of 11 studies containing about 12,000 women aged from 16 to 60-year-old, the incidence of incontinence is ranging between nearly 50–40% of this among this age. Urodynamic have helped us to identify what type of urodynamic stress incontinence, the hypermobility, where the excessive descent of the bladder fall behind the transmission of the proximal urethra, or there is scarring on the sphincter, which is called the IDS. And that's what the picture. And I think since I moved to Kuwait, there is 3 problems I'm facing here. Childbirth trauma, diabetes, obesity is a big problem in women having an incontinence problem. I think you're all aware that childbirth trauma is, and when you have a repetitive children, you have all the ligament is being torn, the nerve will be stretched, and that's why women, they will be coming. No doubt it affects the quality of life from physical activity, confidence, name it. And even if you look to this Canadian survey, which showed that incontinence is, with the urinary incontinence, is the 3rd lowest in quality of life. That is before stroke and Alzheimer's. The European Society have had this logarithmic of managing incontinence. And the first thing before you jump to do anything, you need to have a proper history so you could identify those who have stress incontinence, overactive bladder, which I will talk about it, or those patients who have a bit of complication, who are having a mixed symptom. So yeah, this is a simple logarithmic, which you could find it in the European. When things go wrong and you cannot do the right procedure, which is a simple thing, then you have to advance in managing this patient. Urodynamic, I think urodynamic, we all know urodynamic has many tests you could do it, but it's not a standard practice. Not every patient has to do it. Those patients who have failed surgery, mix those who have straight genuine stress incontinence, these are the patients who they may not need urodynamic. But it's an important tool to help to diagnose these patients. Obviously, if we look conservative surgery, conservative management is the first thing. I think one of the important is the change in lifestyle. Pelvic floor exercises, the use of electric stimulation, vaginal devices, the use of estrogen, alpha. These are all, they are not 100%, they are not more than 30% of improving. But no doubt pelvic floor exercises is a cornerstone, and we should offer it to every patient before we jump and do any form of surgery. The improvement may reach up to 40%, but it's a tool we have to use. Don't deny some of the patient, elderly patient, of some urinary component which help those patients rather than, yes, it is difficult, but I think some patient will deserve to have something before you jump and do any surgery. Other conservative, there will be patients who need to have a sterilization. And that's the difficulty in our culture. It's very difficult to accept that, as Ayman said. But people, they may use the urethral block or the pads. These things which you could offer it to some patient before you go and do a bit of surgery. I think you're all aware of the drug Diloxatine is one of the serotonin noradrenaline reuptake inhibitor. Have been used, but the side effect of that drug in a bigger dose have led in vomiting, nausea. But it still is you could use it before you jump on and do a surgery. And it acts in overactivity for the pudendal nerve, which stimulates the sphincter for this patient. If you look to the surgery, I think there are many surgery. There are more than 100 surgery, which is the evidence base now we should offer it to our patient. There's abdominal, vaginal, and that's what's in the market now. I think the goal of that surgery mainly is to elevate, maintain the proximal part of the urethra, to preserve the compressibility of the urethra, At the same time, to preserve integrity of the urethral sphincter mechanism and allow posterior rotation of descent of the. This is the principle of the goal why we do surgery. I think we're all aware that Birch was one of the oldest operations in the 60s, where John Birch have introduced that operation. And this is an operation which, and Marchet Marquette, it's been moved away because of the cystitis pubis. Colbo suspension is still an operation which we used to do a lot when I was a trainee. That's one of our famous surgery. And then we noticed that the urologists have came into the market where they're doing a lot of sling. At that time, they're using the whole area of the rectus sheath. Paravaginal repair. Sometimes when you do your hysterectomy of this patient, you could repair that. Will it improve? Until the mid-90s, where what we call the retropubic tape procedure came into the market. Professor Olsman, who died unfortunately, have introduced this with the concept of it improve the bladder neck elevation, mid-urethral support, and the urethral compression. And the aim at that time, this is a minimal surgery. Could you do it as a day case, for example, do it under the spinal? And it was a revolution at that time, and everybody started developing this operation. Until a big study came from the United Kingdom, which we call the UK randomized control study, when they compared both TVT and Colbo suspension, and that prospective randomized control study, where there's about 343 patients, where they 170 TVT and about 140 Colbo suspension. And that trial came and showed that the success rates are similar. So the conclusion of that study, which made us move away from the open Colbo suspension, that the TVT is effective, could be done as a day cases, and its success are equivalent to the Colbo suspension. And suddenly, everybody moved, and Colbo suspension became a nasty operation. And everybody is doing TVT. But people forget that. When this product has been introduced, a lot of people who are not having a proper training, and that's why we see patients like this who had injury to the bladder, where the patient comes with a chronic infection, and some they come in with mesh erosion, mesh protrusion, and at that time we're using a lot of different mesh in the market, which have made a lot of problems. And if you look into the production and the scientific on the meshes, it went through a phase until at last we are doing what we call the polypropylene mesh, which has been the acceptable one. And in the other side, the role of urethral bulking agent we became. I think the urologists were the first one who used the cystoscopic urethral bulking agent, and the aim is to narrow and tighten that, but unfortunately the success rate was not that great. And you could see everybody stopped doing Colbo suspension, and the bulking agent went out, and then everybody started using the TVT or similar products. Until in 2001, Professor Delhomme from France introduced what we call transobturator. And suddenly, there was an important publication in IUGA, Argentina at that time, have compared TVT. This is one of the best abstracts at that time, Argentina, IUGA, where they have concluded they're both a good operation, but they found that it's easier, quicker, and the retention is less. And suddenly, everybody went to TOT. There is some people who have reservations, especially people who are pioneering in TVT, they resisted. I do remember in 2003, I was one of the people who moved to a TOT. And then suddenly we became aware that the side pain, and is it from people who do out-in or in and out, and that was a big problem at that time. And don't forget, still TOT is an operation where it could cause a lot of problems. This is a patient who presented with pain in her thigh. She had an MRI, and she had a big abscess, and yes, she had a tape erosion, and that's the picture when they removed that tape, and it's horrible. Needed so many plastic surgery to repair that. So mesh is not a joke. And then suddenly, because of all these complications, people are moving to the mini sling, the TVD secure, the mini rack, adjustable sling. But at that time, the long-term success was not appropriately, and people were not sure. And there was a big failure for all these mini slings. And then that's where people they start talking, what is your choice? I know what's my choice. At that time, my choice was using the transoperator because of the following: less bladder injury, less painful, less vascular, and easy to teach my fellows. But I have always developed the out-in, not the in-out. But still, I used to do a TVT for patients who have a problem of interstitial sphincter deficiency. I still promote the TVT. So you could see over the year, the choice of surgery was clearly the tapes, the TVT, the transobturator, a bit of, and then the colpoid suspension and the urethral bulking agent went very low in the market. When we look to the evidence base that people still do anterior repair for stress incontinence, and I think that's an obsolete operation. Paravaginal is not. But if you look to the tape, if you look to the colpoid suspension, it still is proven, is evidence-based that it's a good operation to do. I do remind you that we all, when we graduated from medical school, we have our oath, Hippocratic oath. Professor Luis Lansaca, he recently revisited the oath, and he's saying that we are doctor and our job is to help patient. We are not gods. We need to counsel our patient, and we should treat a patient, not a temperature chart or a growth. And that's why we have to owe our patient that we need to do a good job. And I think after years of the meshes, and you can see in this picture that what is a little of pain, I have cured your incontinence. And we became so arrogant when we were doing all these meshes in the market. I think by that time, there's so many publications came out of the problem of the mesh, but it's been ignored. Nobody's talking about it. There's so many studies showing that these procedures are going worse. And the problem that I'm going to ask you, did we listen to the patient? Yes, we listened to the patient. Did we interact with the patient? Yes, we interact with the patient. Did we look to the guidelines and everything? Yes, that's what we used to do. But are we going now to change the way how we're talking to our patient? Maybe that's the way. And then you look to some significant complication was underdiagnosed in the last sort of 10 years, where when you ask a woman about problem and you ask the surgeon who performed, there is a contradiction. Women are noticing 31% of mesh complication within 3 months of the surgery. But if you ask a surgeon, 5% recognize the mesh after 3 months. So there is something wrong happening. And obviously, the recent survey in 2018, which we call it the Sling Mesh Survey, have shown there is a significantly underdiagnosed complication because the patient was not talking about it. This group, they form a membership, and they look into about 7,000 mesh done in UK, USA, Ireland, and they look into these meshes. And to the horror, the survey have shown that nearly, for example, 77% of patients felt their life quality has been affected. You find patients who are having anxiety and depression. And suddenly we became aware, yes, we are now doing harm to this patient. At the same time, how long this patient is suffering. And some studies have shown that about 40% of patients, they are suffering for the last 5 to 10 years. And we did not acknowledge them. At the same time, another question is that, do we warn patients for complication? You could see here, 83% feel that the counseling we do is not proper. Nobody told them about the risks they are facing. Unfortunately, in that survey, the majority of meshes we put is about mesh for incontinence. Although now you could see the market, the mesh for prolapses became a big burden. At the same time, some life been shattered. For example, you could see 75% of these patients, a group of 539, cannot enjoy socializing. They can't sit down. They can't enjoy making their love. So women are now have a voice. And then if you look to the regulator, they really failed the patient. If you look at the MRI commission, they have shown that there is a little problem for these meshes. There is another, the regulator, they always look to the device which had a complication, not the mesh we are putting. So for a long time, we have ignored our patient, and although the literature is telling us that patients are in trouble. I will quote from Martin Luther. He said, "Our life begins to end the day we become silent about things that matter." And obviously, the same group of women have looked into the details of the clinical quality, the data and information, and the informed consent. We thought we are informing patients properly. So the same group in 2017, then the campaign against the mesh have started. And this is one of the first group in United Kingdom. And those patients, there are about 10 patients who have complication. They have a survey and send this survey to women who are having incontinence surgery, prolapse surgery, and even to fellows and doctors who are doing this procedure. And it became aware that these patients are suffering. And you could see the amount of painkiller patients are taking, and it is staggering. So what is the alternative? Shall we continue putting the mesh, or listen to our conscience, or we move back to what sort of operation we do for our patient? I think we all agree we're still listening to the patient, and we still interact with them, and we still look to the guidelines, what's happening. I think Professor Stefani today, he's just shown us many publications, and the horrible thing which came out when the FDA said no meshes. But still, the mesh for incontinence is still justifiable. So we need to see how we will work now. I think the campaign is started. You can see from 2017, there's so many campaigns going on talking about how women are suffering from that. Let us look into the role of clinical consent and informed consent. There's a difference. I think when patient comes to the clinic, 1, 2, 3, 4, that's the clinical consent. But I think we need to move now to a well-informed consent so the patient, they know what they are entering. Because in a group of 530, 80% say, nobody informed us about the complication. And then obviously in the United Kingdom, the Department of Health have asked Baroness Cumberland to look into certain problems, and one of them is the mesh. And at that time, NICE, the NICE International Clinical Excellence, have put a document. And at first time, the document came in June 2019, was not that clear. A lot of clinicians were saying that, yes, why should we amalgamate incontinence meshes with the prolapse meshes? So they have to change and then advise patients who are going to be having all these meshes. They have to be consented. They have to have the detail, what type of mesh, what is the quality, how it's being fulfilled. So there was a movement, but the movement have really pushed the mesh for prolapse out. Still, you could counsel your patient for the incontinence. So, sorry, what is the current advice of management now? We need to work very hard for the change of lifestyle. I work in Kuwait, diabetes #1, obesity #3 in the world, and multiparas and a high number of patients. So they need to change lifestyle. Don't deny patient physiotherapy. Push them very hard to go the physiotherapy. And then all the evidence, I was recently in Ayuga in Nashville, the new regeneration of bulking agent. Now Bulkamid became #1 tool before you jump and have a tape. Surgical, I've started doing sling, facial sling. I start carrying on colbo suspension. But the advice also, if you do want to do laparoscopic colbo suspension, you have to be a very experienced laparoscopic surgeon. And there is no doubt these are now the advice from every society. Yes, you could do a mid-sling. TVT is still a good operation, but you have to have a proper counseling, documentation, and telling them what do you expect. Transobturator are not anymore advisable unless in a special condition. And there is no mesh vaginal for pelvic floor now in the United Kingdom. So I still work in Kuwait, and it's a lovely town, and thank you very much.
Thank you, Abu Bakr, for this philosophical critique. I like it. Philosophical critique of the management of stress incontinence and incontinence in general, I think, and prolapse, all pelvic floor dysfunctions. Any questions from the floor? Any questions from the floor? Ayman, please. Here. Thank you.
So, going to be another philosophical question for a philosophical presentation, which I liked it very much. I think one of the concepts regarding actually your Hippocratic authors, how are you going to benefit the patients? Since I came to the Gulf, we have a rate in Doha of about 40% diabetes, a BMI of 40. That's after you've been on Atkinson diet, so that's the usual. Caesarean sections of 4 and 5 is the norm. Now, if you're going to offer these women colpus suspension or facial sling, how are you going to counsel them about the chances of one success, but the complication of such invasive type surgery compared when you put a TOT in 10 minutes? And I know that my complication rate for the last 15 years, because I keep an eye on my patients, is less than 1%.
Yeah.
How do you address that?
Yeah, I accept. I think also since I came to Kuwait, I have the same problem. Diabetes is #1 in the world in Kuwait, obesity is #3, and we have multiparous, and our cesarean section in my hospital is 38%. And I agree. When I joined Kuwait, I did a patient previous 11 cesarean section. I will not dream to do a colpus suspension in that. So yes, I still do tapes, but I think I became more vigorous that I will not put a tape until I counsel the patient about all the risk. But I agree with you. It is very difficult when you see this patient, obesity, more than 40 body mass index, previous 4 cesarean section. Yes, the tape is quick and easy. But the problem is that we have to dedicate time. One patient in a clinic, it takes me nearly 45 to an hour to convince her to go to that. So yes, I share the same difficulty.
Thank you very much. I think in the interest of time, I mean, this is a very interesting presentation. I want to make a lot of comments, but in the interest of time, we have to push with the next presentation. Thank you very much, Abu Bakr.
Thank you.
Okay, we'll conclude by the last presentation in this urogynecology session, and then we'll move to a different session. Again, Professor Salvatori, about evidence-based management of female sexual dysfunction. Female sexual dysfunctions now is a part of urogynecology. Professor Salvatori.
Thank you very much. Quite interesting, it doesn't appear the picture of my hospital. Anyway, just to declare that I don't have conflict of interest regarding sex. In terms of sexual dysfunction, I think that first we should define what is sexual health. That is defined by the WHO as not just merely the absence of sexual dysfunction, but as a complete state of physical, emotional, mental, and social well-being related to sexuality. Now, anything that can alter that statement in a way impair sexual function, and that may happen in different scenarios in urogynecology, for the condition itself or for the treatment that we provide. And that includes pelvic organ prolapse, urinary incontinence, pelvic pain, and genitourinary syndrome of menopause. For a matter of timing, actually I will concentrate on the first two, particularly with regards of the treatment that we can provide. Now, how can we measure sexual function? As you can see, we've got many different tools that have all different grades of recommendation. But certainly in urogynecology, the two that are mostly used are the PISC and the FSFI. They are used worldwide, they are validated in many different languages, and are therefore the most common. With regards of surgery, when we look at the different procedures that we perform, we should look at the effect that we determine when we do hysterectomy, anterior posterior repair, wall suspension, and when we deal women with incontinence. With regards of hysterectomy, we may have some impairment in sexual function for some postulated pathophysiological mechanism, secondary to nerve injury, because we may shorten the vaginal canal, or for psychological effect because of the removal of the uterus itself. In terms of nerve injury, Kiku many years ago proposed that total hysterectomy could improve female sexual function, and therefore, in order to preserve sexuality, was the method that he preferred when he had to do a hysterectomy. However, a few years later, in more than 1,100 women in JAMA, there was this study published with a different follow-up of 2 years follow-up, where actually women who had hysterectomy had an improvement in many domains of sexuality, in the frequency of intercourse, in the reduction of dyspareunia, in quality of life, and in increasing of libido. And a few years later, Jan-Paul Rovers in the BMJ published that it was not important which was the approach to perform the hysterectomy, but if you had an hysterectomy, you improved your sexual function anyway, in the same way. Now, should we consider the volume or the length of the vagina to in a way, understand which effect we can determine in sexuality? It doesn't seem so. Annie Weber, many years ago, showed no difference in terms of vaginal dimensions and sexual active or non-active women, as well as in women who are sexually satisfied or not. Although after prolapse surgery, the length of the vagina was significantly reduced, but that was not correlated to dyspareunia. And this is an important concept. And now there's also the, let's say, the idea that removing the uterus could give a psychological effect. In some cases it may be true, but in some other may be relevant. And Zucchi et al. Looked at that aspect of postulating that the removal of the uterus could be of psychological impact for many women. But comparing, although in small studies, women who maintained or suspended the uterus or removed the uterus with the FSFI, they couldn't find actually any difference in women who were operated for prolapse. In terms of anterior or posterior repair, Annie Weber looked at the effect of this procedure in more than 160 women. They looked at vaginal dimensions, and after a different procedure, anterior or posterior repair or Birch-Kolpo suspension. And concentrating on the results of anterior and posterior repair, the conclusion was that, like for hysterectomy, the dimension was not correlated to dyspareunia or sexual dysfunction. In terms of posterior repair, I'd like to remind what Professor Risk mentioned this morning, that posterior repair may give dyspareunia in a higher rate than anterior repair. We should be very careful in how we perform it, keeping that in mind and counseling the patient preoperatively. This is another study looking at women who were submitted to posterior colporrhaphy plus or minus anti-incontinence procedures. And looking with the FSFI, these authors found a 25% of de novo dyspareunia. So once again, I think that it is very much important to counsel our patients, but also how we perform our native tissue repair. This is a study coming from a group in Rome, very good surgeons, published in the Female Pelvic Floor Surgery Journal, the official journal of the American Urogynecological Society. They evaluated women who had posterior repair for dyspareunia at 12 months. And basically, apart from the improvement in the anatomical outcomes, they found an improvement in sexual activity and in the PISC-12 scores. For the posterior compartment, as Professor Risk mentioned this morning, we may have a transvaginal or transanal repair, and certainly transvaginal repair is preferable because it gives less complication and less sexual dysfunction compared to the transvaginal one. What about mesh? Because of the complication and over-erosion that could be up to, as you can see, 8 to 48%, very variable depending on the type of mesh, the kind of surgery you do, the experience of the surgeon. But anyway, there is a higher risk of developing dyspareunia and hyspareunia, and therefore this should be counseled to our patients. In terms of Volt suspension, we have different papers looking at different procedures, cyclospinals on 51 patients with very good results. This is another study looking at the high uterosacral Volt suspension with the FSFI, the group of Mickey Karam. He showed an improvement in many FSFI domains. So this was another study that showed an improvement in sexuality after prolapse repair. This is another study looking at sacrocolpopexy with a PISC-12, and once again, as you can see, there was an improvement in many domains of the PISC-12, so another good result. So generally speaking, there was a good improvement after prolapse repair with surgery. And again, for mesh, we should see whether the patient falls in the group who had mesh exposure or not. What about women with incontinence? Well, certainly women with incontinence can have sexual dysfunction between 20 and 68% of cases. And this very wide range is secondary to the different questionnaires that have been used, and symptoms are very rarely self-reported because of embarrassment. There is this nice study coming from my hospital, from the group of urologists, Andrea Salonia. He looked at more than 200 women with pelvic floor dysfunction, and he reported that almost in half of women there was some form of sexual dysfunction. And he correlated stress urinary incontinence with a reduced libido, urgency urinary incontinence with some orgasmic impairment, and UTIs with dyspareunia, and this is quite intuitive. But certainly when incontinence occurs during intercourse, this is even more disturbing. And this condition is called coital incontinence. Coital incontinence was defined for the first time in 2010 by ICS and IUGA as the complaint of involuntary loss of urine with coitus. And this may happen at penetration or during orgasm, but have a huge impact on women's life, even on the relationship with the partner. Again, the prevalence of coital incontinence can vary from 10 to 24%, because once again there is a big embarrassment in self-reporting this condition. When we look at the different types of coital incontinence, we made a meta-analysis and a systematic review with Maurizio Serrati, and we basically looked at the literature that was available, and there is a sort of correlation between the occurrence of coital incontinence at penetration with stress incontinence and the occurrence of coital incontinence at orgasm with a diagnosis of detrusor overactivity. And this is consistent with the first study that Paul Hilton published in 1983 that basically was replicated by different authors. In terms of the effect of treatments on stress incontinence, we have not a fantastic data. Many of the cases where sling was evaluated, not validated questionnaires were used, and there were not studies that were specifically designed for that. But nevertheless, what we can see is that there is basically a trend to improve coital incontinence, and generally speaking, only a minority of the patients has a worsening of their sexual function after sling. This is another review that looked at the 23 publications of women who were submitted to different types of suburethral slings. In the vast majority of the cases, 67%, there was no change in sexual function. In 1/3 of cases, there was an improvement in the orgasmic phase. Trying to understand that is too difficult for me. I just report the data. I don't know how can that, in a way, be justified, but these are the data that we've got available so far. With regards of sexual dysfunction and, let's say, other way of treating pelvic floor dysfunctions with pelvic floor exercises or with pelvic floor rehabilitation, in general, we can improve significantly stress incontinence, and so this is good. And there is this systematic review that once again concludes that conservative treatment can be effective in treating not just pelvic floor dysfunction, but also improving sexual function. This is another systematic review looking more holistically at pelvic floor dysfunction and sexual dysfunction. And basically, the authors confirmed that conservative treatment can improve symptoms of urinary incontinence as well as sexual function, that there is an improvement in quality of life and sexual function after surgery for stress incontinence. And they also concluded regarding the OAB treatment that there are no data regarding neuromodulation and urgency urinary incontinence in relation to sexual dysfunction. But when we use drugs, they may improve sexual function, particularly in this review, antimuscarinics. But we've got more and more literature that is coming out that are even specifically on female sexual function with mirabegron, with botulinum toxin, and all of them in a way report an improvement in OAB and sexual function. So which are the take-home message regarding this area? That sexual dysfunction is certainly a common condition in women with pelvic floor dysfunction. We should investigate that because women, at least in Europe, very rarely self-report the problem, at least in Italy, a Mediterranean country. Thankfully, the majority of the treatments that we've got available can improve sexual function, and we should, in a way, include that in the counseling that we do to our patients. There are, however, few specifically designed studies on sexual function and pelvic floor diseases. And anyway, particularly for surgery, internal audit should always be carried out in order to provide data for our patients. Thank you very much for your attention.
Any questions?
Thank you, doctor, for very informative talk. Actually, these days we see a lot of patients of sexual dysfunction with no pelvic prolapse and perineum is normal. And second, do you have any study of sexual dysfunction after episiotomy? After episiotomy.
Say it again.
After episiotomy.
After episiotomy.
Dear.
Certainly, this is another huge universe. No, pain after delivery is a huge problem. That again, once again, it may be secondary to different pathophysiological mechanisms. Could be secondary to tears, to episiotomy, to stretching of the pudendal nerve. There are neurophysiological studies showing that during the crowning, there is a stretching of the pudendal nerve that is 15 times longer than what is normally its normal dimension. And I think that for the treatment, we should try to identify which is the most likely cause of dyspareunia. That could be sometimes also a bad reconstruction. Unfortunately, I see sometimes in Italy very bad reconstruction even of episiotomy or vaginal lacerations that are certainly the cause of dyspareunia and of sexual dysfunction. and we need to basically reoperate these women. Sometimes there is a laxity that by itself is not well defined, but vaginal laxity gives certainly a reduction in the sensitivity of the vaginal canal, particularly in the multiples. And in this case, we should listen to our patients and try to propose treatments that we can improve their function.
Thank you very much for your presentation. I have one question regarding the use of vaginal laser, because it's been distributed everywhere, and you know, in the market, they always market the use of vaginal laser for treating pelvic floor POP means, but I think it should be used for vaginal rejuvenation in the menopause, according to the lectures and the workshop which I attend. If you have any idea regarding the use of vaginal laser, and you can explain it.
Well, thank you for these questions. Before starting this meeting, I was saying, thank God I'm not going to talk about laser because I get bored. but no, thank you. This is a very important question, actually. And well, unfortunately, I have to say that sometimes distributors, and they take all the responsibility for that, advertise the machine, and even doctors, actually, for conditions where there are no evidence at all. And if I very clearly say at any occasion that prolapse cannot cure vaginal prolapse. As you well know, vaginal anatomy, the normal anatomy is maintained by different components, fascia, ligaments, and muscular components. With the laser treatment, we can improve the lamina propria and the epithelium of the vaginal canal, but certainly we cannot get into the fascia unless we do that intraoperatively, and certainly we cannot go deeper in the muscle, and we won't have any effect in the muscle apart from damaging it. So no, laser cannot treat prolapse.
Do Ayman here?
Again, thank you for a very elegant lecture, and seem to be sharing the same interests. But again, this is something which, again, is something that I came across when I came to the Gulf area comparing to the West when I was practicing in the UK. And we don't actually ask the patients why are they having the operation in the first place. Some of these studies that report sexual function is the impact of the surgery in sexual function would differ completely if you ask the patient, is she having the surgery to improve the sexual function or not? So it becomes your outcome measure. And I find that actually this is very common and very sensitive issue in the Gulf, that repeat posterior repair. I mean, I've seen a patient who had 6 and 7 and 8. With every delivery, they go and have a posterior repair. And the aim is to improve sexual function. So I really think we need to take the results of the studies of sexual outcome that's done in a Western setting, in a completely different view, when you come to a different sort of culture and social background, because I was astonished by the differences of women's perception of sexual function. That's number one. But the number two as well is the psychological background to sexual dysfunction. I think it's huge. So without actually you jumping to do a pelvic floor repair or vaginal laser or rejuvenation, I think that needs to be really deeply explored.
Yes, thank you very much for your comments. I totally agree with the first one. There are different cultural approaches in different parts of the world, and to be honest, I was trained in UK. The approach in UK is totally different of how we approach in Italy and in the Mediterranean countries in general. And this is something that we should account, and that's why I think that as physicians we should in a way have our own, let's say, audits of what we do, how we perform procedures, how we propose procedures. But yes, I totally agree. With regards of the second part, there is a psychological approach, particularly for the removal of the uterus, I think. No? I think that this is quite a delicate issue. It's quite a delicate issue that we should respect. Women may have a different attitude in wishing to maintain the uterus or not. I think that our task is to try to give the evidence that obviously if a woman is in a fertile age and she wants to have a further pregnancy, this is obvious that we should try to do our best to suspend the uterus in the way we are more confident and where we get the best results. In postmenopausal women, though, I try to make a different counseling. I tell them that what are the data that is, regardless the approach that you use to suspend the uterus, you have a 30% of recurrence. That the uterus is the heaviest organ in the pelvis, and if the uterus comes down again, it's more likely that also other part of the vaginal canal can descend. And then if a woman wants to have the uterus maintained, I try to respect her wishes anyway. In postmenopausal women, though, I'm not a strongly believer in uterine suspension. It's quite curious to also to mention that there are only 5 reports in literature of women who, well, we don't know which is the real life, obviously, but in a fertile age, there are only 5 cases reported in literature who maintained a uterus. 3 got pregnant and had a voluntary abortion, and 2 didn't have any pregnancy. So.
I totally agree with Dr. Ayman. Our population are totally different from Western countries. And from my experience, when the patient comes to you at the clinic, they usually complain, or the main concern is sexual dysfunction. Now, when you examine the patient, you will come to know that she has incontinence, she has urgency, she has all the symptoms, but her main concern is sexual dysfunction. And that's the reason why many people, they come back, keep coming again to do the operation on and on, because the main concern is that sexual dysfunction, not the incontinence itself. So I think we have to listen to the patient, we have to tailor our method of treatment according to the patient concern. And I think that's mentality.
Again, I agree. I think we should respect each other wishes of our women, the cultural background, the religious background. We should take that in mind.
On that note,
I have one question also. Is there any place for Manchester repair with limited options for treating patients with POP? Manchester repair.
All right. Yeah. Well, in Italy, we don't do the Manchester repair for. I did many Manchester repair when I was in UK. In women, the procedure is not well accepted. Apart from the classical suspensions, we do sometimes the occlusive procedures in elderly women with all the comments that Dr. El-Mahdi made before, and we do the Lefort procedure. This is what we do.
the last question.
Thank you for the excellent presentation, but if you don't mind, Dr. Abu Bakr, the question is for you. You've talked about the management, the order or the sequence of managing patient with stress incontinence, and you came up with new thing to me also, that bulking agent would be used before the sling procedure. To my knowledge, the only reason that sling procedure came in the beginning before, or we're adopting sling procedure, because we have the study that documented or concluded that both Birch and sling procedure have comparable outcome. And that's why we move towards sling procedures. How comparable is bulking agent to sling procedure to put it as a priority before the sling procedure? Thank you.
Bulking agent is introduced in the market recently more and more because of the complication of the mesh. And that's why there is a move. I was in Ayuga in Nashville, and the whole talk of Ayuga was the bulking agent and moving away from tape, TVT, TOT. And that's why I concluded in my presentation that because of that difficulty, those group of women who are now fighting, so do you know there's, in the States there's about 500 million lawsuits against companies, and you just said all the mesh has been stopped in there. So bulking agent and colpoid suspension come back by default because that's the only option you have. I agree bulk meat in my hand is about 50–55% success for a year or two, and they come back. So we need to be honest to our patient the way how we counsel her. I don't know if you have any comment.
No, I've got the same position. I totally agree with you, Abu Bakr. And yes, there is now this tendency to push, particularly for what has happened in the UK, to push the injectables forward, but I've got the same position. If I may, I take the opportunity just to go back to laser just for a second, and just to say once again that it doesn't treat laser, it doesn't treat prolapse. We are doing a trial anyway that is in a way copying what has already been done for local estrogen. There are two randomized estrogen versus placebo controlled trials showing that the women in the estrogen group had a better perception after surgery for prolapse regarding the placebo group, and we are replicating the study with the laser.
On that note, we're going to break for 15 minutes, and Professor Salvadori, thank you very much.